Good morning, everybody. Welcome to PCH Grand Rounds. It is my pleasure this morning to introduce my friend and colleague and my boss, Dr. Chirag Kapadia. Dr. Kapadia is a native of New Jersey and went to medical school at New York School of Medicine. He did his pediatric residency at Children's Memorial Hospital in Chicago and then did his fellowship in pediatric endocrinology at Children's Hospital of Philadelphia. He's been at PCH since 2008. He served nationally as the chair of the Drugs and Therapeutics Committee of the Pediatric Endocrine Society, and he's also served as on the board of directors regionally for the Juvenile Diabetes Research Foundation, JDRF. He's been the division chief of the Endocrine division since January 2017, and his talk today is titled Endocrine Side Effects of Inhaled Glucocorticoids. Please welcome Dr. Kapadia.
Thanks, everyone. Thanks for giving me the opportunity to talk. Please feel free to stop me, interrupt me. I tried to make it straightforward. I thought this was an important topic. I can tell you how I got involved with it. It was not a particular area of expertise of mine, but a few years ago I had served on a Pediatric Endocrine Society committee, the Drugs and Therapeutics Committee, and several case reports started to come to our attention about patients who had had adrenal crisis, and there wasn't an identifiable cause except for the fact that they'd been on fairly high-dosed inhaled corticosteroids for a while. Can everybody hear me? So we decided to look into it a little bit further, and myself and a couple of colleagues from that committee ended up writing a paper about what we found, and this presentation is based largely off of that. So I'm going to start with a case presentation. Then I will go through several sections with regards to dose and formulation and potential side effects. And there's a lot of information as I started to learn about this that surprised me in there about how inhaled corticosteroids and corticosteroids in general work. And then I'll tell you my conclusions from each section, and then I'll finish with a table with all of our take-home points together. So a case presentation. A 7-year-old girl presents with a new onset seizure. Her blood sugar was 24 when the EMTs arrived. Head imaging and septic workup was negative. Has a history of asthma and allergies. Is on Flovent 440 micrograms per day and Zyrtec. Had gotten oral steroids, but not constantly. 4 months prior was her last burst of steroids. Her lab showed a cortisol of 2.1 at the time of her seizure and her hypoglycemia. So lesson 1, hypoglycemia, time to get labs. Next morning, a morning cortisol was done. It was quite low. It was 0.8 micrograms. Normal would be 9 or 10, depending on the laboratory standard you use. And then they did an ACTH stimulation test to see if they could induce her to make cortisol, and the peak was 1.4. So she's adrenally insufficient, and that's the cause of her hypoglycemic seizure. So that is an uncommon case, but not as uncommon as you'd think, as you'll understand as we go through this data. Inhaled corticosteroids are used as effective first-line treatment for several respiratory illnesses, most commonly asthma. Side effects are pretty rare, but the number of people in the population on these drugs is high, and therefore the total number of adverse events that you can find is not insignificant, because although for each individual patient the incidence is rare, and the overall population, you find a fair number, as we'll get to. Excess steroids, we've known this for years. Excess steroids when taken by mouth or injectable or IV can cause decreased linear growth, decreased bone density, Cushing's syndrome and obesity and weight gain, suppression of the hypothalamic pituitary adrenal axis, and hyperglycemia. So I guess one of the take-home points is that inhaled corticosteroids can also cause each of these things. However, in most cases, the effects are extremely mild. and therefore have no significant clinical impact. But in rare cases, in patients who are at higher risk for a variety of reasons, either because their dose is high or they have other comorbidities that put them at risk, the risk is higher of each of these things occurring, and they may be more severe. So I'll start with dose and formulation effects. This was sort of interesting to me when I started to learn about it as a non-pulmonologist or non-allergist. So what's interesting is that the clinical effectiveness of the drug and the systemic absorption of the drug have a strong positive correlation that you can't really address by making a better device or changing to dry powder or something like that. I'll explain why in a second, but the bottom line is the part that's effective is the part that goes to the lungs. The part that absorbs to the blood is also the part that goes to the lungs. So for years, efforts have been focused on making sure that none is remaining in the mouth, and so that very little gets swallowed or gets absorbed from the oropharynx. That's a worthwhile goal because it will decrease local side effects. However, the part that you swallow, or the part that's in your oropharynx, your liver takes care of it. Your liver gets rid of it. So it's actually the part that goes to your lungs that gets into your bloodstream. I'll show you the exact data on that in a second. So real efforts in the future to focus on safer inhaled corticosteroids that can have safer side effect profile and more efficacy will actually need to focus on things like being cleared more rapidly from the blood or being less likely to be stored in fat cells. So this is from an article in 2007, and it sort of explains in a schematic what I was just talking about. So you take your inhaled corticosteroid. Depending on how well you take it, 60 to 90% of it will be swallowed, and actually nowadays you can get that number down. But the thing about the amount that gets swallowed or remains in the oropharynx or the GI tract is that in most cases, the liver can inactivate it, more than 90% of it. And so only tiny little bits get into the systemic circulation from whatever you swallow or remains in your oropharynx. Again, that doesn't mean getting rid of this part is not good. It is good because you don't want thrush and you don't want other local side effects. But systemically, the part that you swallow doesn't have most of the effect on the rest of your body. It's actually the part that gets deposited in the lung that helps your airways, but that is also the part that's absorbed into your systemic circulation, into your bloodstream. And that tends to be what leads to most of the systemic side effects that we see. That's sort of counterintuitive and certainly is different than my understanding of how inhaled corticosteroids might cause side effects before I started looking into this. So inhaled corticosteroids are delivered via a variety of devices. A metered dose inhaler, dry powder, nebulizers, or a metered dose inhaler plus spacer. I think nowadays for most of our kids, they'd be using a spacer if they were using good practice. Oral deposition and lung delivery are also affected by the size of the particle. Small particles, which the manufacturers have been progressively, the newer generations tend to be smaller. Less stays in the mouth, more gets to the lungs. The drug that's deposited in the oropharynx is useless in that it has no respiratory benefit, so obviously you don't want it there, and it does cause local side effects. However, as I just noted, it has minimal systemic effect. Most or all of it undergoes hepatic first-pass metabolism. There's a slight variation in the compounds, but most of them are cleared pretty well. So other things that we learned is that in asthmatics who have worse asthma and more airflow obstruction, their airways are probably leakier, and the amount that gets into their bloodstream is probably higher from their lungs as compared to a well-controlled asthmatic. This has treatment implications, which I'll get to towards the end, but it basically means once you have them in control, there is a guideline in place that you're supposed to step down treatment. That component of the guideline is actually extremely important because you may need a lot for a little bit, but as you heal their airways, you can usually back down. After absorption, some forms bind tightly to proteins and thus have little systemic effects. Some forms are more rapidly cleared and thus have little systemic effect. However, some forms are more lipophilic, some of the forms of steroids. And so they're cleared less rapidly because they hang around in your fat cells. So here's a little schematic of some of the common inhaled glucocorticoids. And this should say percentage not metabolized via hepatic first-pass metabolism. So this is the percentage that sticks around after the liver gets a hold of it. You see fluticasone is almost all gone. The amount of fluticasone that you swallow may cause thrush for you, but it's not going to hurt your rest of your body in most cases because the liver takes care of most of it. Cyclesinide, again, probably even better than fluticasone in that response. Budesonide, a little more sticks around, and beclomethasone, a fair amount of it does tend to stick around, even after the liver gets a hold of it. Particle size, they all have varying particle sizes. Again, the smaller the particle, the less likely you'll get into the oropharynx in the first place, because it'll just get through easier. Protein binding. So protein binding is good, because if you bind to proteins, eventually you're cleared, and while you're bound, you're not having any systemic effect. So cyclesinide, again, comes out pretty well. Unfortunately, at the time we did this paper, and even since then, there's less data on cyclesinide in the pediatric population, but when I look at the characteristics of it, it certainly seems to have the lowest side effect profile theoretically. And systemic clearance is not that high for fluticasone, very good for cyclesinide and beclomethasone. Again, because fluticasone tends to be one of the ones that's a little bit less protein bound and actually is also known to be a little bit more lipophilic than the other compounds. So this maybe not have direct clinical impact, but it sort of explains why some have a side effect at a particular dose and others don't. So the ideal non-side effect causing inhaled corticosteroid would be deposited mostly in the lungs, because again, the oropharynx actually is not helpful in any way. This wouldn't reduce the systemic side effects, but it would reduce local side effects. Any part that was deposited in the oropharynx would undergo a high rate of hepatic first-pass metabolism. It or its metabolites would be tightly protein-bound and not free-floating, and it would be cleared very rapidly from the circulation. So when the drug manufacturers look at future generations of inhaled corticosteroids, this tends to be part of what they're looking at. You know, the manufacturers have been looking at the side effects of inhaled corticosteroids for decades, actually. In the early 90s, there was a whole flurry of cases as well, and the manufacturers of fluticasone really did some studies about it at that time as well, and some of the data that we've presented actually comes from those studies. All right, so this is a small slide. I apologize for that, but I guess I just wanted to make the general point that there is, for each compound, a low daily dose, a medium daily dose, and a high daily dose in terms of what the National Heart, Blood, and Lung Institute recommend in terms of dosing depending on the degree or the severity of your asthma. And really it tends to be these patients in this category here, in the high daily dose, who tend to be at the highest risk of side effects. One caveat I'll give is that when we did our research, it didn't line up, the side effects and these dose categories didn't line up exactly. But they were close enough that we felt that from a clinical standpoint, it would be easier to understand if we did make the point that if you get a patient who falls into the high daily dose category, you should be paying attention to this issue. So again, our primary conclusions were that clinical effectiveness and systemic absorption have a strong positive correlation, and that device and formulation modifications can only partially address this, and that you may actually need new compounds if you truly want to eliminate all side effects. So that's the first part of my talk. I'm about to move on to the next part of the talk. Before I move on to that, which is going to be the impact on linear growth, any questions or any thoughts before I move on?
We say that when corticosteroids in pain, they have some effect in the linear growth. Now, let's suppose that the child is going to grow until he is 18 or 20. So if we use the inhaler, and the corticosteroid inhaler, for 5, 10 years, when you have that, this is 8 or 10 years that the child has lost, that the nucleus, hasn't grown because they have been inhibited. So definitely is going to end up with a deficit in linear growth.
Yes, that is correct. Now, it tends to be very mild. So I actually will go through the data on the linear growth in just a second. It is an effect, but it's pretty mild. Depends on what you want to consider clinically significant, but in almost all cases, the effect is less than an inch. Okay, so I'm going to move on to linear growth. So the primary conclusion in our linear growth section, and I'll explain why as we get through the next slides, is that in the majority of patients, the inhaled corticosteroids have a minor and short-term effect on growth, and very mild, but potentially persistent, long-term effects. So they do have a short-term effect. You see growth drop off when you start these drugs for a year or two. I think most of you know that. And then you start to show a little bit of catch-up, but even in the long run, there's that small difference does persist. It's not 100% catch-up that occurs. These growth outcomes, this is a judgment call, were acceptable considering the respiratory benefits of the drug. Obviously, they're on it for a reason. And multiple asthma exacerbations is worse than being shorter by a centimeter. Patients at higher risk include those on additional growth-impairing medications. And I think most endocrinologists will tell you that the patients who they have seen who might have had this effect tend to be also maybe on an ADHD drug or some other drug too that also impairs growth. And then you add them all up, and they're all pretty mild by themselves, but then they start to have an impact together. Effects on linear growth, how does it happen? So steroids suppress growth hormone secretion. They downregulate the growth hormone receptor. They reduce IGF-1 production and bioactivity, and they suppress collagen synthesis at the growth plate. So effects on linear growth, short-term effects. Nemometry is an interesting technique that they use mostly in Europe, where they basically measure from your knee to the bottom of your foot. And apparently that's the best way, that's one of the best ways to measure short-term growth. I would never imagine measuring growth over 2 weeks, but these guys did it on using very sophisticated technology, and they said there was actually a reduction in the very short term on budesonide. These were a couple of European studies by Walthers. Using beclomethasone, 200 micrograms twice a day, they were effective improving lung function. These were the doses that I needed to get to improve the lung function and asthma symptoms in this Dutch population. They showed a significant reduction in linear growth, 0.28 standard deviation, which in comparison to the controls was significant, over the course of 1 year of treatment. Standard deviation in total is about 2 inches, so it's still not, a huge amount, but it's something. In a subsequent study, the group found that doubling the dose of beclomethasone had more impact than the lower dose, so it was a dose-dependent effect. They also found that the higher doses didn't always have a greater clinical benefit than the lower doses. Similar findings with fluticasone have been seen. Again, data in ciclesonide remains limited in the pediatric population, but it did not seem to show growth impairment using that nemometry methodology, at least in one study. Long term. Most linear growth retardation effect occurs in the first year. Most of it seemed to go away after 2 to 3 years. However, there's probably still some persistent effect. Growth is a very complex thing, and you never know what the person would have been if you hadn't done this or that. And we run into the same thing in our growth hormone studies. A lot of it's based on prediction. A lot of it's based on what a similar control group will do. But from fairly decent data in the growth world, there's probably perhaps slightly more than a 1 centimeter persistent long-term effect. So the bottom line is, what you've probably heard, that there's only a short-term effect, is mostly correct, except for in a few children. So at the most, there's a small difference in height, demonstrated by these gentlemen. But remember, the studies are up to 400, these guys are about a centimeter apart, by the way. So remember, the studies are up to 400 micrograms a day. If you were using more than that, maybe there would be more, but people haven't looked at that as closely. So the primary conclusions are the ones you probably have to worry about are the ones who have other comorbidities leading to impaired growth as well. So if you have them on inhaled corticosteroids and they're also going to be on an ADHD medication, and then they're going to periodically have to use oral steroids, and then they're a picky eater and they don't eat well. You start adding all those things up, and each of those things, minor effects on linear growth independently, but altogether they could add up to a patient with impaired growth. All right, so I'm done with the linear growth portion. I'm going to move on to bone mineral density. So my primary conclusions here are that inhaled corticosteroids have mild effects on bone mineral density that, again, like linear growth, they don't reach the threshold of clinical significance. However, we would recommend to consider measures to ensure vitamin D sufficiency on patients on ICS, especially high-dose ICS. So the pathophysiology of the bone mineral effects. They impair absorption in the gut and the kidney of calcium. They inhibit GnRH secretion and therefore sex steroid hormone secretion, and that leads to diminished bone density. They suppress growth hormone a little bit, as I mentioned before, and that can reduce bone mineral density. And these hormonal alterations result in net bone demineralization, but the effects very dramatic if you're on oral steroids chronically, and very mild in most cases for ICS, inhaled corticosteroids. So 3 studies found no deleterious effects in children 12 or younger, and a study of 48 prepubertal children using a high dose, 670 of budesonide or beclomethasone, did show a dose-dependent decrease over 1 year. However, that was about, it looks like I didn't put it in there, but there was less than a 1 standard deviation bone mineral density decrease. So a study of older children and adolescents treated with high-dose fluticasone propionate and a mean dose of 770, so huge doses. These kids have really severe asthma. For a duration of about 2.9 years, plus or minus 1.6 years, the lumbar bone mineral density was more than 1 standard deviation below the mean in 35% of subjects. So most subjects, 65%, still had a variation of less than 1 standard deviation. But when you got to super high doses, we did see a third of patients drop their bone mineral density by more than 1 standard deviation. So very high, the previous doses mentioned in the previous slide, even some of those were high dose, maybe not such an effect, but this kind of really high dose that I don't think I've seen very often does seem to have enough of an impact that I'd worry about it. So the bottom line is, at standard or even high doses, there's probably a minimal effect of these drugs on bone mineral density. But at very high doses, there's probably some risk. Vitamin D may ameliorate some of these effects. So how do you address that? I'll give you something sort of not clinically proven. My practice has evolved on vitamin D to essentially putting everybody on it if there's any concern that they don't have enough vitamin D. I mean, if you look through the literature on vitamin D toxicity, nobody who goes on 1,000 or 2,000 a day of vitamin D gets toxicity. There's absolutely 0 reports of going on 1,000 to 2,000 a day, any kid, any adult, 1,000 to 2,000 a day going on vitamin D and getting toxicity from that. Never happens. The cases of toxicity are doses that are substantially higher than that. People are just loading up on it, 10,000, 50,000 units, huge doses, then they can get toxicity. The other cases of toxicity are people made mistakes in the administration. You have the kid on D-Visol and they're supposed to get 1 ml and the parents are giving 10 mLs. Then we've seen toxicity. But at standard prescribed doses or recommended doses of vitamin D, you don't see toxicity. So I feel that the process of checking and rechecking vitamin D, maybe is a little out of hand sometimes. So I just advocate to put them on. If you have a concern that they might have bones at risk, put them on 1,000 to 2,000 of vitamin D. It is not going to hurt them. It can only help them. Essentially, I just take these kids and I put them on 1,000 units of vitamin D and call it a day. And encourage them to have good calcium intake. If they don't have good calcium intake, try to put them on some calcium too. All right. So my primary conclusions are as mentioned. So the next section is hyperglycemia. So patients with diabetes mellitus in whom inhaled corticosteroids are initiated or have an increase in their inhaled corticosteroids may require changes to their diabetes regimen. Now, before I looked for this, I didn't know about this, but now that I know about this, in my diabetes patients, type 1 or type 2, if they go on ICS or their dose goes up, it does seem to impact their insulin requirements or their A1C a little bit, if they've already got diabetes. If they don't already have diabetes, that doesn't mean we can't account for it. It just means that we might need to change the regimen a little bit. If they don't have diabetes, then the ones at risk are they're already at very high risk of type 2. Maybe they're in the pre-diabetic range with an elevated glucose, but not quite to the diabetic range, or they have severe family history or severe obesity. Those patients probably should be tested after you start inhaled corticosteroids. They probably have a mild hyperglycemic effect, and for some people that mild effect can push them from non-diabetic to diabetic. It happens, but rarely, but it does happen. This testing, however, is fairly routine, and if you had severe obesity and a strong family history of type 2 diabetes, we'd probably test you for diabetes anyway, whether or not you were on ICS. But if you are starting somebody on ICS who's of that risk profile, probably something you should follow up with the labs in a few months. Glucose effects are dose dependent. The higher the dose, the greater the effect. So the hyperglycemia, why does it happen? Steroids cause decreased insulin sensitivity, decreased glucose disposal, and increased gluconeogenesis. But in actual practice, studied in a large VA population of adult males, the ICS were not associated with hyperglycemia in non-diabetics, and then amongst diabetics, as I mentioned, their glucose went up. So for those already predisposed on a dose-dependent manner. A small number of adult studies have linked hyperglycemia among diabetics but not non-diabetics to ICS use. And a large Canadian study, this was sort of surprising, but I do want to make a point that they were using huge doses, and I don't know why they were using such huge doses, but some of the doses were above 1,000 micrograms a day. In that study, a large Canadian study, and they have some fairly good health tracking in Canada, a third to half of patients who were diabetic already and were not on insulin progressed to needing insulin with such high doses. I haven't seen any of our pediatric colleagues using such doses, so I was surprised to see that, but I suppose in adults sometimes such doses do get used. The only pediatric study to date examining the hyperglycemic effects of ICS reported a small but significant increase in non-diabetic children's A1C. So their A1C went from 5.3 to 5.5. You're still not diabetic, but there was a change in those children. So the primary conclusion is the ones who have diabetes may need an adjustment to their regimen as you go on these medications. If you're already at extremely high risk of type 2, there's a small chance this could push you over the edge of that. And glucose effects are probably dose-dependent. Higher doses, greater effects. All right, now I'm going to move on to probably the thing I really want you to know about, and goes back to our first case report, which is the hypothalamic pituitary adrenal axis. All the other side effects I've mentioned so far are fairly mild, not only in their incidence and their degree, but also fixable most of the time. This one is dangerous, and most of the scary things that can happen with ICS revolve around this. So in a meta-analysis in the past, less than 400 micrograms a day, they didn't find evidence of adrenal insufficiency. However, Patel in 2001 reported on about 30 children who had adrenal insufficiency, mostly attributed to doses of ICS. And out of those 33, 7 of them were not on very high doses. They were just on standard doses, and they still had it. Now, these symptoms, these patients, when going back in retrospect, maybe had other symptoms, such as poor growth, poor weight gain, so other signs that the ICS were having a more than typical impact on them, but nobody really noticed it till they got to the point of having adrenal insufficiency. Others have reported a similar phenomenon, and in 2002 in the UK, they have decent tracking in the UK of the population. They looked through a decade's worth of data, and they found 28 children with adrenal insufficiency from ICS identified. You know, if you were to look at our population in comparison to the UK, that would mean that we'd have something close to 150 over a decade. 23 presented with hypoglycemia. Most were high dose, but about 10% of them, again, so a small number of them, even without the high dose, seem to develop adrenal insufficiency. So mostly it's the high dose, but there's a small population that seems to be more predisposed. They did account for things like frequent oral steroids, and those patients were taken out of their case reporting the best they could. In France, about a decade's worth of data showed 46 cases, and 18% of those were not on high doses. So there is probably some risk of adrenal insufficiency at high doses, and even a very small risk at low or standard doses. So again, this data does not mean that 18% of patients on standard dose corticosteroids get adrenally insufficient. It means out of all the cases of adrenal insufficiency, 18% or 10% of them were not on the high dose. So you got to look for the patients who are going to be at risk of this. If they're presenting with more than typical growth suppression as a result of going on their inhaled corticosteroids, you know, we went through, it's pretty mild. It can happen in the first year, and then they really should be catching up to almost normal, where they were before. At the most, there's a centimeter difference after year 2. If they're not showing that catch-up, that's a patient you should be paying attention to with regards to this. If there's a patient whose weight gain drops off after going on these drugs, you should be looking for it. And I probably should have said, if they get Cushingoid on these drugs, you probably should be looking for adrenal effects as well. And if they're presenting with severe fatigue, hypoglycemia, or vomiting, yes, obviously that's a situation in which you need to look for it too, but obviously we want to get to the point where we recognize it before that hypoglycemic event occurs. So at higher doses, there's a higher risk from the data, but there is some risk even at the lower doses. Sort of ironically, with these drugs, non-compliance, of course, avoids the side effect because you don't get the drug as much or as consistently, and so you don't suppress your adrenal axis. However, in the long run, if you're non-compliant, you also might get in the hospital more. You might need oral steroids more, so that may prove to be not true. So the primary conclusions, again, are that HPA axis suppression, though rare, is the most worrisome and dangerous potential side effect. Children on high-dose ICS with consistent adherence should be tested in a routine manner. I'll explain how in a second. Children, and then the other ones to check, other than the ones who are on the high dose, are the ones with growth failure, anorexia, weight loss. Also, if they're experiencing that and they didn't have that before their ICS, probably should be tested for adrenal insufficiency. Children on ICS with hypoglycemia or altered mental status obviously should be immediately evaluated and treated if necessary. So I'll talk about how you test that in a second. Fluticasone, I told you about the characteristics of the drug in the past and how it's interesting that highest effectiveness sometimes can go together with highest risk of side effects because the place where the effectiveness occurs and the systemic absorption occurs are the same. At least from the UK study, most of the adrenal disease was all fluticasone. You always have to take these data with a grain of salt, but in the UK, I would have said, well, of course it's mostly fluticasone because that's what we use mostly. We use fluticasone. That's the main drug. So of course most of the cases are going to be fluticasone, but I guess in the UK, in the 2000s, that wasn't actually true. Beclomethasone was the primary drug that they were prescribing most of the time, had very minimal numbers of acute adrenal crisis. Out of the total adrenal crisis that occurred, most of them were, 90% of those were fluticasone, even though they weren't prescribing a lot of fluticasone in the UK at that time. So that is probably, why is that true? And that's probably because fluticasone is lipophilic, and it hangs around in the system a little bit more than some of these other drugs do. It doesn't mean you can't use it, but in light of this data, the recommendations on the threshold at which you check in fluticasone is different than in beclomethasone or budesonide. I believe I have a slide about it in a bit, but at fluticasone at 400 or 440, that's considered high dose. And in the other drugs, you have to get to above 600 to 800 before you're considered micrograms, before you're considered high dose. And part of that is the clinical effectiveness and the side effects tend to go together. So you need less fluticasone to be effective, but a lower dose can also induce side effects. So how to test for HPA axis suppression? So there's a lot. This is if you've ever consulted us about an adrenal insufficiency patient in the ICU, you understand that we don't exactly know how to test this perfectly because there's not perfect testing for adrenal insufficiency in children or adults. There is perfect testing, but we don't want to do it because it involves inducing severe hypoglycemia and seeing what happens. So since we don't really want to do that most of the time for our hospitalized ICU patients or our other patients, we're left with some measures that are imperfect. Basically, if you do the stim test, then you're going to find more insufficiency than if you just do a baseline cortisol, say anything less than 3 is too low, and otherwise you're fine. Those are two different approaches that have been used to try to identify adrenal insufficiency. Obviously, if you do the more complex test, the stim test, you're likely to find a little more. In some studies, in addition to cortisol, ACTH is a useful test. So the way that I test for adrenal insufficiency in a patient at risk is I start with a morning cortisol. Morning cortisol should be done fasting, first thing in the morning. It's important to be fasting because if you ate sugar for breakfast, that actually suppresses your cortisol a little bit. So you should be fasting first thing in the morning. Timing is extremely important. No matter how many times I think we explain this to our patients, once we hear fasting, they think they have license to go in for the lab draw at 9:30 or 9, and for most of their studies, for fasting labs, you can do that, but not for cortisol. It really does have to be before 9 o'clock in the morning or it's not really very useful. The other thing about morning cortisol is that you have to do it late enough, too. In the hospital, we love to do 4 a.m. labs, but everybody's cortisol is 0 at 4 a.m. if they're properly functioning. So it has to really be between 7:30 to 9 in the morning to do a morning cortisol. So I would do a morning cortisol and an ACTH. If I get a low one, I'll repeat it. And if it's still low, I will move on to a stim test. So what is low? Now, if it's less than 3 on a morning cortisol that's done the right way, that is extremely unusual. And if I get one that's less than 3 and then I do it again and it's less than 3, I may not even do a stim test, right? Because I was doing it in a patient who already had risk. So 2 values of morning cortisol less than 3, from my understanding of the data in a patient at risk, is diagnostic. I'm not doing the stim test at that point because the stim tests are also imperfect. But if I'm between 3 and 9, I feel it's unclear, and I may need to do a stimulation test. And if I'm above 9, I think I'm okay. Cortisol testing is imperfect. There are a certain percentage of patients who have a morning cortisol above 9, but still don't respond properly to stress situations. There's some patients who are between 3 and 9, you stim them and you're like, oh, why did I do it? They're obviously totally normal. But it's imperfect testing, but it's the best we have. So the next part of my talk is going to be about higher than higher dose and questionable increase in effectiveness with greater side effects. So this is a low dose stim test. Synacthin, which is, we call it cortrosyn here in our hospital, it's synthetic ACTH. Using a low dose of that, what percentage of the people have affected low dose stim test? And what you see is that the percentage, this is the dose of fluticasone here on the bottom. This is the percentage with who fail a stim test. Okay, as you go on a higher dose, more fail. But as you go to a higher dose, you don't keep getting more and more effectiveness. You know, on this curve here, the difference between 200 and 750 in terms of effectiveness is not very much. So I talked earlier about stepping down therapy, and what I meant by that was once you have good control of your asthma, lowering the dose of your inhaled corticosteroid is very good practice. It's part of the recommendations that the allergy societies and the pulmonology societies do put out. But I know that it's not, you know, asthma is a very common condition, and many primary care doctors are also practicing it. So using a higher dose, a high daily dose at initiation can be justified, or titrating up to that to achieve control to avoid exacerbations can be justified. But once control is achieved and the lungs appear to be showing healing, it's good practice to start to dial back the dose a little bit. All right. So again, my primary conclusion is that HPA axis suppression, though rare, is the most worrisome effect. Children on high-dose ICS with consistent adherence should be tested routinely, and those with symptoms such as growth failure, anorexia, weight loss should be tested in a routine manner, and obviously those with hypoglycemia or altered mental status should be tested and treated. All right. This is a summary slide. I will get Dr. Olson's team to send this out towards the after the lecture. It summarizes pretty much what I've just told you in terms of recommendations and what to do. Growth suppression, I guess everybody's at risk, but if you have a decline more than 2 standard deviations that's persistent, you probably should refer or test. Adrenal insufficiency, who's at risk? Symptomatic patients. Okay, we talked about what the symptoms were. Here they are again. And then even asymptomatic ones who are on high daily dose, or if they're on inhaled corticosteroids, plus they have rheumatoid arthritis and they're on other steroids, you probably should look into this. Or if they're losing weight or have very low BMI, they're at risk. So, like I said, in a patient at risk, less than 3, I consider adrenal insufficiency likely. If it's between 3 and 9, or 3 and 10, depending on which one you want to use, I consider doing a stim test, and above 10, I leave it alone. Above 9 or 10, I leave it alone. If you do a stim test, a value of less than 18 micrograms per deciliter at the peak is considered abnormal. The peak on a stim test is the 30-minute mark, not the 60-minute mark, just as an FYI. Okay. Hyperglycemia, if you've already got diabetes, you're at risk. Or if you're at significant risk of developing diabetes and you're worried about whether that patient was going to develop diabetes already, then it's probably something after you start these drugs you should look at. If they start to develop a fasting glucose above 100 or an A1C above 6%, that would probably be indicative that they're developing something and you should refer them. And then we already talked about the worsening control in patients who already have diabetes. So regimen adjustment may be in order. And decline in bone mineral density, like I said, I just put them on vitamin D. At the time we wrote this paper, it was 400 to 800. I've just taken to 1,000 at this point because it's been easier to get patients to take it because they usually end up taking it like 5 days a week at the most. So you could check them and correct them to greater than 30. If you're really looking for bone mineral density optimization, you actually need a vitamin D near 50 for bone mineral density optimization. 30 is sort of a lower limit. So I know there's a variety of ways to correct vitamin D. You can do weekly regimens, you can do monthly regimens as necessary. So what if you can't get a morning cortisol done? I put this in there even though I felt like there wasn't a tremendous amount of data to support it as of yet. not as much as there is for cortisol testing. People have been doing DHEAS testing, it's the adrenal androgen, and if it's low, then that patient may have adrenal insufficiency. So if you really just can't get your patient to do a morning test, if you did a DHEAS, if it was very low, I'd be pretty worried about it. Again, there's less data behind this test than the other tests. All right. So I think I'm on to my question. Before I move on to our question, should I comments now or should I do the question now? Okay. All right. So this is unfair because the slide was like 20 slides ago. But which of the following represents a high daily dose of inhaled corticosteroids? So you can respond online or you can text that. This is a total daily dose. All right, very good. People are starting to put answers in. How do I know everybody's answer? Okay. I think that's good. All right, so the correct answer is all of the above. As I'd mentioned, fluticasone has a lower threshold. Oh, there we go. Everybody's getting it right. Fluticasone has a little bit of a lower threshold than the other drugs for both for being considered high daily dose and the highest degree of clinical efficacy, but also for risk profile. All right. And that is my talk. I'll open it up for questions, comments.
So what happens if you find somebody has a low cortisol level? Do you put a stimulator or a beta agonist and try to change their asthma medicine? Or do you give them hydrocortisone?
Yeah, so, I think you'd need your pulmonologist or an allergist involved, but there are steroid-sparing medications like Singulair, which are known to be steroid-sparing. So yes, if they're not already on those or maxed out on those medications, I think that they should be. And you should spare the steroid dose as much as you can without losing control of their asthma. And then the other thing that needs to happen is now that you know that they're adrenally insufficient, firstly, longer term, as you can achieve control of their asthma, you'll look for step-down therapy. That's not something you might be able to achieve immediately. And you'll need to instruct the family that the patient is adrenally insufficient. And I have seen patients who this was severe enough in that, the weight loss was pretty bad, or their lack of weight gain was pretty bad, and I had to start them on steroids. I had to start them on hydrocortisone, a small dose, to just get them to be able to gain weight again. That's a little more rare, but everyone who's identified with adrenal insufficiency at the least needs stress doses during illness. So that would be one of the major implications. If you were to identify this and the cortisols are low and the stim testing's low, is during illnesses, during procedures, they should be getting stress dose steroids.
Have you ever, when the steroids, or when the inhaled steroids, if they were able to be stopped, has that been shown to reverse the suppression?
All steroids, inhaled or oral, once you stop them, the process of recovery begins. So yes.
No, but I mean specifically with inhaled.
Yes.
There's so many kids with asthma, there's so many kids with Floralin. What I was wondering is, you have so few cases, is it just by chance that you have some kids that were adrenally suppressed that happen to fit in?
That's always possible, but adrenal suppression is not, I guess there's never adrenal suppression without some reason. There has to be a reason always to be adrenally suppressed. So, these patients in these studies, they were evaluated for other causes as well that were not found of adrenal suppression. I don't think that there's a baseline population that has no particular cause but just happens to be adrenally suppressed. I don't think that there is such a population. So.
Always lab error.
That's true. That's right.
The question is, I really just wanted to know if you could fill Cox hospitals with, you stopped it and they got better.
So I will say from personal experience, the answer is yes. We have a patient who was pretty interesting. It's more complex than even this, but is Dr. Pimentel here? She saw her. So there's a patient who had coccidiomycosis disseminated. I think that's what was their underlying diagnosis, and they were on antifungals. What? Posaconazole. They were on posaconazole, and posaconazole, and they were also. She also had asthma, and she was on a fairly high dose of fluticasone. And I think it was meant for treatment for her cocci as well. And she got a double effect. She had the inhaled corticosteroids absorbing from her lungs a little bit. Now in her, remember I said the liver clears the part that you swallow, but the posaconazole impairs the ability of the liver to clear the drug because it impairs P450. So the part that she swallowed wasn't getting cleared as well. She became severely adrenally insufficient. She became Cushingoid, first, and then she became severely adrenally insufficient. She ended up with cortisols less than 1 on multiple testing and a stim test less than 1, even with stimulation. And she had severely diminished bone mineral density. Her DEXA scan had a Z-score of -9, which is crazy. And she had severe drop-off in her linear growth as well. So we got her off steroids eventually and tried to use other steroid-sparing drugs. And I think she might be now on a very small amount, but she's on, I think, 88 or 44 of fluticasone at this point. And her adrenal axis recovered as a result. So that's one example. And I have one other as well who's not as dramatic and has just happened to be on fairly high dose. So this patient was on 440 of fluticasone, but also was on nasal steroids, 2 puffs in each nostril twice a day. So the Flonase and the fluticasone added up, and you got to a pretty high dose by the time you were done. And she presented with anorexia and weight loss. And I actually put her on hydrocortisone for a little bit. Her weight loss improved. Oh, I'm sorry, and her cortisol testing was very low, and a stim test was very low. And I put her on hydrocortisone for a little bit. Her weight gain improved. I gradually, we worked with her pulmonologist to try to figure out a lower dose and some steroid-sparing medications for her. So she got to lower doses, although she's on 220 now. We basically eventually weaned the hydrocortisone oral that I had started, retested her, and she passed her testing. So that's a couple of case reports that I've personally had. Again, the number of people on this medication is many, many thousands. And so when you find 100 cases or 150 cases in a decade for many, many thousands of patients, you're not saying that, it's incredibly common. But I think it's something to test for if you're on the high daily dose for a long time.
In terms of presenting in a renal crisis, I read a case study once of a patient who presented with a low sodium as their presentation for a renal crisis. So can you talk a little bit about, how many low sodiums are you going to see compared to hypoglycemia?
So you may not see many low sodiums. So the mechanism of this is that you suppress, you give corticosteroids, which are cortisol equivalents, and you suppress your body's ACTH production. And when you suppress your body's ACTH production, then you go back and now you suppress your body's cortisol production. But ACTH doesn't most of the time have very much effect on aldosterone production. And therefore, because you won't suppress aldosterone, you might get a slightly low sodium, but it won't be very severe, even if it does occur. Cortisol has minimal effects on sodium. It's mostly aldosterone. So when we see our adrenal insufficiency patients with pretty severe low sodium, it's mostly the aldosterone part that does it. This won't do the aldosterone part.
People are stable on steroids and doing well and don't have other symptoms. If they have to undergo a surgical procedure, would you first them get anesthesia for a day or so to be on the safe side?
If they had a high daily dose for more than a year or two, I would probably test them to see if they were deficient and then burst them. I mean, I feel like, if you did just give them a burst, probably there's no harm, but what tends to happen, or at least what we see happen, is you give them the burst, then maybe something happens post-op, you're not sure, so now you got to give them some more steroids, and you don't know whether it's related to the adrenal insufficiency or not, and you can't test them because you've already just given them a burst, and that alters the testing. So textbooks are textbooks, I understand that. The ideal way would be to test them, not just treat them, because you might end up in a situation, if you have a post-op issue, then you're stuck treating. What? I'm sorry, she's back there now.
What do you consider routine testing
If they're on high dose for more than a year, I consider to do a morning cortisol.
no, sorry, how often?
How often to do it?
Yeah, how often?
Once they've been established on the dose and they've been on it for a while, I usually would only test them once, unless their dose went up again.
And then when these kids come into the hospital, do you want us to, and we know they've been on high-dose steroids for a couple of years, do you think it's going to be testable in the hospital, or should this just be an outpatient?
If they're in the hospital, they're probably sick. It's actually not a bad time to test them, because you have to do it in the morning, and you have to be careful about the timing. But if anything, you're more likely to pass your test when you're sick, so not a bad time to test. I mean, we don't get a lot of consults for that, and I don't think that we're advocating that we should get that. Yeah, I mean, if somebody is sick, it's really a good time to test cortisol. They should be making a lot. Yeah, then don't do it. Yeah, there's a lot of things to consider there. If they had, dexamethasone for croup, don't test their cortisol. So, okay.
It seems to be that we haven't made any progress treating asthma for the last 30 years. We have been using the same medication. Until lately, that we have systemic, immunological inhibitor. We have also phosphatidyesterases for inhibitor. And also we have the biological medication. How do those medications compare with the corticosteroids, with the side effects in treating asthma?
I'm not an expert in that. I think I'd have to defer your question. I can't speak to the absolute clinical effectiveness of those other drugs. I mean, I know that they are effective. I know that when we run into this situation, we want to use some of those things, but I don't know which. I still think that for most experts in the field, they regard ICS as first line and most effective. Sorry. Thanks, everyone.